but tissue growth may happen even after late years, okay. But development is a continuous process. This is from womb to tomb. What is the meaning of womb to tomb? From birth to death, or not from birth, even from conception, okay, from conception to death. You can learn new skills, you can learn many things, okay. So this is our newborn, then it becomes infant, and then toddler, preschool, and then school age. We'll come to that, the stages. So now, what is the stages of growth and development? This is an MCQ alert. You will get many MCQs from this one slide, okay. Acha. So what is the stages of growth? So when the one cell, I told you that there is one cell which is becoming us. So definitely there are few stages that we cover, okay. So first stage is the prenatal period. And what is the prenatal period? So from ovum, that is the 0 days of gestational time, to 14 days, that is 2 weeks, it is called ovum, okay. Achha. Then from 14 days to 9 weeks, few books says 8 weeks, few books says 9 weeks. So we have gone with 9 weeks. So 14 days to 9 weeks, it's called embryo or embryonic period. Then after that, from 9 weeks till birth, it is called fetus or fetal life. We all know that. Okay. So this whole period is the antenatal part. And now see, this is the perinatal period. What is perinatal period? It is written, but somebody just tell me, what is perinatal period? What? Huh? Right. So this is a overlapping period which is a few few weeks in the antenatal period and 7 days after birth. Okay. And this is very important. This is very important in terms of saving the child. That I was this is a very good period to, like, we can do some intervention to save the child. We can do some intervention, like now fetal therapies are there. We can do many good things at this particular period. This is covered by both in the gynae obstetrics and also in the pediatrics. So this is an overlapping of two streams. Now the child is born. So there is postnatal period. And postnatal period, what is the postnatal period? Till 20 days of life, 28 days of life, okay. Some say 1 month, but this is mostly 28 days, that is 4 weeks, okay. And now I have written this, but this is not from birth. Infancy is from 28 days to 1 year for medical purposes. Toddler, what is a toddler? Toddles, okay. তাহলে নড়বড় করে হাঁটে যারা, হ্যাঁ, তো 1 to 3 years, okay. আচ্ছা, preschool, preschool means 3 to 6. All of you have gone to preschool, huh? Have you gone to preschool? Right, all of you should go, okay. Okay, you remember that, huh? Okay, very good. School going means 6 to 12 years. And then from 13 to 19 years is adolescent. Some even include 20 years. So just 2 years back, almost 1 or 2 years back, you all were adolescent. And I feel that you still are. Huh? Okay. So first of all, what is the implication of all this name? Normally when history taking, we say the child has come. So this will beautify your history taking if you can use these terms. Right. So when presenting a case of 1 to 3 years, you can say this toddler is coming from this place, okay. Then maybe when you are taking history of a 4-year-old child, maybe you can say that this preschooler is coming from this age. So that gives a very good structure to your history, okay. Chalo. Okay, so now this is very, very important, okay. Whatever we are saying about under 5 mortality and infant mortality, then neonatal mortality, all are covered here. That this is the first 1000 days. What is the first 1000 days? From from the conception to the end of pregnancy, that is 270 days. and then next 2 years, that is 365, 365. So total 1000 days. And whatever the researches are coming up, that if you can protect, if you can give good protection in terms of nutrition and immunization and everything, and developmentally supportive care to a child, then this child will be growing very well and developing very well. Okay, হাসছিস কেন? কি ব্যাপার? Okay, chalo. So now I will coming to this factors influencing growth and development. So everything is clear. First 1000 days. What is first 1000 days? Till 2 years. From conception to 2 years. So that means the first 270 days the child is in the mother's womb. And how we can do something when the child is in the mother's womb? Can we do something? I'll come to that. Okay. So what is the main factors? Whatever you do, whatever like the part you you achieve, and whatever you do, you are combination of these two things. That is your genetics. Can you go beyond genetics? Huh? Can you go beyond your genetics? Cannot, why not? That is environment. Okay, so suppose one child was born in Nigeria, okay, in a very poverty stricken area, and this child is adopted by a Italian couple. So genetically the child will be black mostly, okay, and then maybe low birth weight, maybe undernourished, underweight. But once this couple adopt this child, so the nurture has changed. Environmental factor. So this child will speak Italian, he will love pizza. Huh? So why you cannot go beyond your genetics? You will definitely go beyond your genetics, right? I hope that like all of you, all your parents are not doctors, right? So you have already gone beyond it, right? Okay, chalo. So see, this is a continuum and hierarchy of system, how we are influenced, all of us. Sometimes we forget our identity as Homo sapiens, right? We forget it, that we are organelle, we are an organism, right? So from molecules, see, this is the molecule, from that organelle, then cell, then tissue, then organ, then nervous system. So it is growing. From one cell to the whole nervous system is happening, and then it is feeling as a person. Isn't it a beautiful thing that this brain is making you think that you are Dr. Mandira Roy? How? Have you thought about it? Your brain and her brain is almost normal, but you are Somi and she is Aishwarya. Why? So how the brain is creating separate identity for you, right? This is very interesting. Okay, so then one person, then 2%, then the family, then the community, then the whole culture. How culture is shaping your development and growth. So everything is important. Do you think that? Morning, sir. Okay, so do you think that one kid who is in a very safe environment will grow similarly as some child in a war-stricken area of Syria? No, right? Okay. So that is comes the society, the nation, the biosphere, the whole biosphere. Everything is important for a growth and development of a child. So this is a multifactorial thing. So first of all, we'll discuss about the fetal period. So what are the factors that are influencing in the fetal period? Already discussed. Huh? So there will be some degree of characterization from parents. So if you are born, like if the child is born from a tall parents, the child will be taller, right, than the other people. Okay. So and there are many other factors. Say some genetic disease is coming from generations, so that will affect growth and development. Okay. Now gender. Gender in general, it is seen that boys are taller than girls. So gender plays a role. And also in case of gender also, there are specific diseases that may occur in particular gender. So it may cause some differences in the growth and development of the child. Okay. Then fetal hormone. This is very important and also MCQ. Huh? So the most important hormone in the fetal life is thyroxine. Okay. Also insulin, but the first is, that is why it is greater than insulin. Okay. And also glucocorticoids, that is cortisol. This is important. Okay. And that's why you see, when during the antenatal history, we ask very clearly that did you had any hypothyroidism? We ask mother, no? Hypothyroidism, diabetes and hypertension. These three things, they are very much related to growth and development of child. So that's why we ask this history very clearly, that did you have this kind of problem? Okay. Now thyroxine helps in the brain growth mostly, and you know, the brain, almost 70 to 75% of brain growth and development that happens in the antenatal period. I'll come to that. Okay. And now there are few growth factors that are important. So growth factors, both kind. Okay. Growth factors may be pro growth or anti growth. Okay. So there are some stimulatory, some are inhibitory. Why we need inhibitory? Why we need inhibitory growth factors? So we need to cut down also some shaping, some pruning. Okay. Then growth factors, mostly we discuss IGF-1 and IGF-2 at your stage. But there are many other factors like epidermal growth factors, transforming growth factors. So there is alpha, beta. Alpha is pro-growth and beta is anti-growth. So like that. Okay. And then some placental factors. So this is a combination. The mother, placenta and the fetus. This work as an unit. Okay. So it works as a unit. It forms the blood vessels, the maternal, placental and fetal. They make the circulation and supply the nutrients, like that. You will learn that in far details in gynae obstetrics. Okay. And there are some maternal factors, obviously. So there will be fetal factors, placental factors and maternal factors. So placental factors, what are the placental factors? In general, it is seen that most of the species, mammalian species or whatever, the size of placenta is directly proportional to the size of baby. So if the placenta is not growing or the placental circulation is poor, then the growth of baby will hamper, right? Okay. So it may be like some thrombus in the circulation, there may be some placental insufficiencies. The mother may have very high blood pressure, that the blood is not reaching the baby. Okay. And then maternal factors. So maternal factors is most important. That is why marked red is the maternal malnutrition or undernutrition or maternal anemia. These are the factors that are badly affecting the fetal growth. So if the mother is not eating well, the teenage pregnancy, the mother is herself is so underweight. So how she will provide the food for the child? No? Okay. And then some maternal infection. We know about torch infection. Have you heard of it? Torch infection. What is the full form of torch? Bolo? T. Acha T tai bol. হ্যাঁ একটা গ্রুপের আছে torch. Okay. So torch infections, we generally call it, it's a group of infection. We call it torch, that is toxoplasma, then other infections like Zika, all these things, okay. And then some cytomegalovirus, okay, and then syphilis, like that, and herpes simplex. So these all can, you know, it all can affect the growth in a bad way. Growth and development. There are many other factors. There are many other which are vertically transmitted. Many other infections like HIV maybe. Okay, but these torch complex is a notorious for growth and development. They affect growth and development very badly. Okay. Then maternal substance use, mostly smoking and alcohol, and there may be others also. Okay, so that also badly affects the child. Okay, then maternal illness, we have already discussed that. Maybe some chronic illness, maybe some acute illness, maybe the mother was very sick in the COVID period. Many pregnant women, they had COVID, very bad, severe COVID, they even died. So like that. So maternal illness, obviously, that can lead to defect in the growth and development. Okay, and then very important is psychological trauma. So mother was in very much of stress, traumatized, maybe schizophrenic, maybe some antipsychotic, was on some antipsychotic. So that may also affect the growth and development. Okay. Now we are coming to postnatal. Now the child is born. Now what may affect the growth? Most important? Bolle dekha ache re. Huh? Nutrition. Yes, very good. Okay. So genetic factors, obviously. So if the child has some syndromic, some chromosomal problem, may say Down syndrome, very common, huh? Down syndrome, or maybe other Turner syndrome. So that will lead to short stature. So growth will be hampered, right? Okay. And gender, again, boys are taller. Okay. And then some fetal factors that we have already discussed, that yes, if the child was not grown properly in the intrauterine period, there may be IUGR. Okay. So if the child is, born with low birth weight baby, so there is a tendency that it will catch up growth late. So maybe till 2 years, it will not catch up well. Okay. So it will be underweight. Okay. Then nutrition, very important. Good food, already discussed in last few classes. Okay. Then hormonal influence. So what is the most important hormone here after the postnatal period? Most important is the growth hormone here. Okay. So intranatal period, thyroxine, here growth hormone. Thyroxine definitely will play a role, but everything. So this is not one single thing. This is for MCQ purpose. All the hormones are equally important. Okay. So growth hormone, insulin, thyroxine, each and every hormone is important, and it creates a perfect balance. Okay. If anything is up and down, then it will be a problematic. Okay. And then infections. So on the very first in the very first thing I said, that under 5 mortality rate. So the under 5 mortality, 30 to 40% of that is due to infections. So recurrent infections, cough and cold, it can be acute respiratory infections, can be GI infections, that may cause growth faltering, bad effect on growth and development. Okay. And then there are social factors. What are the social factors? Social factors may be like there is poverty, socio-economic status is not good, some cultural belief that okay, we don't eat something like we don't eat like in the vegetarian background. So there will be some deficiency of protein, okay, and energy. There may be some deficiency of vitamins also in particular sect. Okay. So natural resources. So there is not safe water. There is no good food, not available. Okay. War-stricken area, very bad, very poverty. So it will affect the child. Okay. Then cultural factors that I discussed already, that there may be some avoidance or some particular food choices that okay, we eat this, and that may be a toxic thing. Okay, in many parts of our country, they use kind of many Ayurvedic medicines or some natural herbs, and that may be harmful for the child, right? Okay, so that are the cultural factors. Okay, now emotional factors, how it will affect the child. So suppose one father who says, if you don't complete the homework, I will not let you eat. Okay, but it may happen. right? So parenting styles, so very authoritarian parents, and the child was angry, jao ami khaboi na, and it happened for say 6 months. So the child will be undernourished, huh? Or there may be abuse, some child abuse may be there. See, abuse is not only physical abuse, not the mardhor, huh? There can be emotional abuse also. Huh? Okay. And then psychological trauma, there may be even sexual abuse. Okay, so all this will affect the child in a very bad way. Then the most important, screen exposure, not present in any book right now, but this is affecting the children in a very, very big way. Okay, now most of the children, I think you all are also, while you eat, you are glued to your phone. Estella coming, Yasir Desai coming, fossils coming. So the food is reaching your stomach, but the nutrients are not reaching well. You don't even know what you are eating. Okay, but you are grown enough. You understand yourself. But the child is not establishing the connection to food. The child does not know. A 5-year child does not know that he is eating how aloo siddo looks. Happening today. Okay. So screen exposure, any kind of bad screen exposure. So again, so we have discussed everything, how all these levels are affecting the child growth and development. Okay. Now principles. There are some principles of growth and development. It cannot happen, no? Like today I am growing like this and then tomorrow I will be growing like this. So there are a fixed pattern and there are some principles of growth and development. So what are the principles? So growth and development, though we discuss it separately, but it occurs concurrently. It occurs concurrently. We cannot separate it like that. Okay, we may discuss it separately, but whenever I discuss development, there will be, it's vice versa. Growth is dependent on development, development is dependent on growth. So it occurs concurrently and continuously, that I said. Acha. Then rate of growth varies in different stages of life. We know that? Okay. Then growth and development is unique for each individual. This is very important. Okay. Whoever has attended our OPD, you have seen that the 50 to 60% patients, they come with this complaint, Dr. Babu, bachcha kichu khache na, ar ojon badche na. Huh? This is the complaint. And you will see that with some people, we say, are theek ache khabe. So we reassure. And for some, what we do? We do test, we do bone age estimation, ye karo, wo karo. Why? Why we are very discriminative people, right? For some we are doing good, we are doing test, and for some we are not doing anything. Is it so? No. So it depends on the potential. So whenever the child comes and we see that growth is faltering, we look at the mother. Sir does that. He said, "Tumi erokom, to tomar bachcha kirokom hobe." And that is actually true, right? So if the mother is undernourished, so we see the potential. We see is there any systemic illness present or not. We see that and then we reassure that maybe okay, it's nothing. It's just the mother is obsessive. Huh? Okay. So it is unique for each child. It may happen that the both child, these two newborn, they are born with the same weight, but they will not grow similarly. Maybe at 1 year. So these two newborn, they both weigh 3 kgs. One became 9 at the age of 1 year and one became 10 kgs at 1 year. Both are normal. Okay. So this is unique for each. And now for development purpose, also a little bit of growth purpose. So there is particular direction to development, that it starts from head to toe. So from very first, we start holding our head straight. Then we sit, then we stand, and then we walk. So that means it's from head to toe. So cephalocaudal direction or cephalocaudal, you can say, direction. And then from proximal to distal direction. There is a photograph. So see, this is from head to toes. Okay, and from proximal to distal. And how it is proximal to distal? How we can explain it? That the development is happening from proximal to distal. You see that when the child first learn to use his arms, okay, arms, and there is a phase of development where he balances himself on only on the arms and stoops, okay, and then he starts using this. So start grasping the objects in a correct way, in a mature way. So see the maturity in the 5-6 months, his holding is like this. Then after that, he is holding like this. Then after inferior palmar grasp, so 8 to 9 months, he is holding like this. And then he holds like this. So pen holding. So children, they play with ball. How they hold the ball? Like this. Hold the ball. Catch the ball. Like that. So they start holding the ball very well. But when they hold pen, in a very later stage. Okay. So this is how the development happens. Okay. And now see, this is the change in the proportion. So we can see that from the very first, the head is so big. So gradually the head size decreases and the body size increases, the trunk size changes, and the limb size is increasing over the time. Obviously this is a pictorial graph, this is not, this is maybe just 50 centimeter, but this is a big 5 foot taller. So this is a pictorial graph that how the body proportion is changing, okay. So this is all we are discussing. This is the somato pattern of growth. This is called Scammonn's curve. Okay. So pattern of growth, see the somatic growth or the musculoskeletal growth, like we discussed, it starts happening and then it reaches its peak at around 18 years. It is reaching the peak. And meanwhile, it is, see this is a steep part and then going slow, and then again rising and going plateau after that. So the child, the infant, it grows very well in this first, in the antenatal and in the infancy part till 1 year, 2 year. But after that, the growth seems a bit slower. And that is the time when the patients come and say, "Amar bachcha kichu khache na, kichu barche na," because this is the phase, okay. Achha. And then brain growth. So we are discussing the tissue growth separately. Brain growth, as we have already discussed, the brain growth is almost, see, so the peak is around 2 years. So by 2 years, that is the first 1000 days, brain growth is almost complete. Almost 90% brain growth is complete. Okay. Then there is growth of lymphoid system. Lymphoid system is related to which system? Immunity? Huh? Immunity? Okay. So, you can see that lymphoid system is peaking around 6 to after 8 years until 12 years. Okay. Another thing is that the gonadal, this is the reproductive growth. See, the reproductive growth is very slow in the first 12 years, and then just the puberty happens, the adolescence happens, and there is a spark. There is a growth part of the gonads. And what is the main hormone that acts in the reproductive growth? This is the same thing, graph separately. So brain growth, the peak is around 2 years, somatic growth curve is like this, then lymphoid growth is around 6 to 8 years, they peak, they come with the tonsillitis. And then they regress after 12 years. Okay, and then gonadal growth is like this. This much is clear. This pattern is clear. Okay. And this is about dentition. I will again discuss this later on when we do the assessment. But this is again a very important part of child's growth, the dentition part. Okay. So what happens initially? There are primary teeth which fell off, and then the permanent teeth comes. So generally it starts from 6 months, that is the lower incisor which starts from 6 months, and then it grows and then around from 6 years onwards, it starts falling off one by one, or maybe two sometimes at one time, and then till 12 years there is a period of mixed dentition. What is the period of mixed dentition? From 6 to 12. এগুলো তোরা ফরেনসিকে পড়েছিস তো, হ্যাঁ ফরেনসিক, no? Okay, so in that period the permanent teeth also comes, so there is a period of mixed dentition, and we can estimate age from teeth also. We'll come to that. Okay, so I think I'll just give a outline of what are the parameters that we'll look for, but will not go to assessment this class. In next class, I will talk about the assessments, but what are the growth parameters that we see? This is already discussed in last classes. Acha, length till 2 years, correctly said. Can you? Okay, and then height after two years. Okay, with which instrument we measure length? Right, very good. Okay, so another parameter is body mass index, then another is head circumference, chest circumference, mid-arm circumference. These are all important. Okay, mid-arm circumference, right, MUC. Then body proportion. What is body proportions? We measure it. What is? ওটা তো আগেই বলে দিয়েছি। Body surface area, no, this is basically upper segment and lower segment. So there are some genetic conditions, some achondroplasia, there may be many other. Short stature, in the evaluation of short stature we use this upper segment lower segment thing. Okay, and then skin fold thickness we see for subcutaneous fat estimation in case of malnutrition. Okay, and what are the domains of development? What is gross motor? No, grasping is fine motor. Gross motor, remember, gross motor is the big movements. Big movements. What are big movements? Like walking, so head holding, what? So it is using the bigger muscles, and fine motor is this one, writing. Okay, so the smaller muscles of hand is getting involved in the fine motor. Also in the legs also, fine motor. Okay, then language, receptive language and expressive language. Have you heard of it? What is the meaning of receptive language? Baba, এটা English terms, bol. Reception, what is reception? Marriage party. Reception, the day after wedding. So, receptive. So, it is the how we are understanding it, receptive language. And expressive means how we are talking. This is the talking, expressive, writing. So, that is how we are expressing ourselves. Okay. Acha. Then socio-personal. What do you mean by socio-personal domain of development? মারবো না মন নিজের আছে। আচ্ছা, তোর socio-personal is like, suppose when we grow up, we develop an understanding. Hey, do not disturb the class. Hey, sir, chup. Acha. So in socio-personal, we develop some understanding about our social structure. So the child or the infant who is growing up or developing well will very soon recognize that this is the mother, this is the father, this is my grandparent. Okay, so they have this understanding, and they also have understanding of their personal needs. That okay, I am feeling sleepy now, I am feeling hungry now, and they communicate like that. Okay, ki mama give me milk. Okay, so that is the socio-personal part. And then vision and hearing development is very important. Otherwise, if you cannot see and cannot hear, then you will not be able to develop well. Okay, so we'll finish it here. We'll quickly recapitulate that what we have studied today. Change in the size, increase in the size. Okay. And then what is development? Attaining some skills, functions, right? Okay. So the difference clear? Okay. And the stages, all good? Okay. Then first 1000 days. What is first 1000 days? Why we need to know this? Why? Huh? Bolo? Why it is right? Why it is important? লেখাই তো আছে রে বাবা, না এদেরকে বলছি why it is important. This is the peak time of growth and development, and if we give proper support to this phase, we can change the future of the child. Okay. Acha. So influence genetic, that is nature, your nature, and then environmental factor. Remember? Okay. And then these factors influencing. So most common, most important hormone in fetal growth, thyroxine. Postnatal period, most common hormone, growth hormone, and in reproductive phase, right? Okay. Then most common factors for badly affecting the fetal growth, maternal malnutrition. For that, what we'll do, we'll catch the teenage, from teenage onwards. So we are supplementing that with them with iron, folic acid and all. We'll discuss that later. Okay. So postnatal period, psychosocial factors, principles, clear? What is cephalocaudal? What is the meaning of cephalocaudal? Head to toe, proximodistal, from center, from midline to peripheral. Okay. Body proportion, clear? Pattern of growth, clear? So what is the peak time of brain growth? 2 years. See, at 2 years, 2 to 3 years, brain growth is peaking. Okay. The same thing, dentition. Okay. Then growth parameters, and then domains, clear? So done for today.
Patient is coming from persistent fever, cough, drowsiness, mental confusion, কাশি কমছে না অনেক দিন ধরে, ঠিক আছে? এটা এক্সরে করালি, এক্সরে হ্যাভিং আ নিউমোনিক প্যাচ, রাইট? there are about two types of patch, right? এবার একটা হয় লোবার নিউমোনিয়া, another is a interstitial pneumonia. লোবার নিউমোনিয়া মিন আমার লাংসে জানি তো কত, রাইট সাইডে কটা লোব আছে বল? 3 lobes, right? আর লেফট সাইডে 2 lobes. Each and every lobe get affected, that is called lobar pneumonia. Suppose আমার রাইট সাইডে লোয়ার লোবটা অ্যাফেক্টেড হয়েছে, আর যদি সেরকম প্যাটার্ন না হয়, পুরো ইউ হ্যাভ সিন কোভিড এর কখনো এক্সরে বা সিটি স্ক্যান কখনো দেখেছিস যে একদম পুরো গোটা লাংস জুড়ে সাদা 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 প্যাচি প্যাচি ইনফিল্ট্রেট হয়ে আছে, দ্যাট ওয়াজ কল্ড ইন্টারস্টিশিয়াল নিউমোনিয়া, ঠিক আছে? তো সেটা ভাইরাল করতে পারে, কিছু অ্যাটিপিক্যাল অর্গানিজমস করতে পারে, that is called atypical pneumonia. So we can divide it cap into two parts. Another one is a atypical pneumonia, another is a lobar pneumonia. Atypical pneumonia কারা করে? এখানে যে এজেন্টস গুলো আছে, হ্যাঁ, any kind of viral infections cause atypical pneumonia. Again, mycoplasma, Haemophilus influenza, chlamydophila, these are all called atypical pneumonia. Staph strepto generally cause bacterial pneumonia, a lobar pneumonia. All are bacterial onset, but they are caused generally lobar pneumonia. And in case of healthcare associated pneumonia or hospital acquired pneumonia, whatever, previously it is termed as hospital acquired pneumonia, now it is called healthcare acquired pneumonia. Generally they are multi drug resistant. কেন? কারণ সেখানে কন্টিনিউয়াস আমার ওখানে কোন অর্গানিজমস গুলো, মানে মেকানিজমটা কি, আমার হসপিটালে অ্যান্টিবায়োটিক এক্সপোজার অনেক বেশি, সেখানে যে ব্যাকটেরিয়াগুলো চারিপাশে ঘুরে বেড়াচ্ছে, সবাই খুব একটা হাত ফাত ধুচ্ছে না, কারোর হাতে লেগে থাকছে, কখনো কোনো এনভায়রনমেন্টে থাকছে, দ্যাটস অ্যান্টিবায়োটিক্স আর এই অর্গানিজমস আর হ্যাভিং আ মোর ড্রাগ রেজিস্ট্যান্স দ্যান কমিউনিটি, রাইট? দে আর মাল্টি ড্রাগ রেজিস্ট্যান্স বেসিক্যালি। তাহলে সেই অর্গানিজমস গুলো যখন কমন সেলস গুলো এনি হাউ বাই হেলথ কেয়ার ওয়ার্কার, যে পেশেন্ট একটা ভেন্টিলেটরে আছে অনেক দিন ধরে, আমার হাত ফাত পুরো হ্যান্ড হাইজিন ভালো না, তার এক একটা লাইন্স করা আছে বা কিছু করা আছে, সেখান থেকে একটা তার নিউমোনিয়া হয়ে গেল, ঠিক আছে? তো সেই রকম কাইন্ড অফ সিনারিও দিস ইজ কল্ড হেলথ কেয়ার অ্যাসোসিয়েটেড নিউমোনিয়া। তো তাদের ম্যাক্সিমাম যেগুলো হয় সিউডোমোনাস, অ্যাসিনোটোব্যাক্টার, ক্লেবশিয়েলা, রাইট, অ্যান্ড সামটাইমস এমআরএসএ, মেথিসিলিন রেজিস্ট্যান্স স্ট্যাফোরিয়াস, ইকোলাইও হতে পারে, বাট ইন কেস অফ নিউমোনিয়া these three organisms or four organisms are more common. What are they? First, Acinetobacter. Now the trends of Acinetobacter and Klebsiella is rising. আগে সিউডোমোনাস ছিল, এখন সিউডোমোনাস ইজ বিং রিপ্লেসড বাই অ্যাসিনেটো। যদি ক্রিটিক্যাল কেয়ারে কখনো কোনোদিন কেউ যাস, নিশ্চয়ই যাবি তোরা, ইউ ক্যান সি দেয়ার ইজ নো ড্রাগস ইজ অ্যাভেলেবল, রাইট? ঠিক আছে, যে এক একটা সব মাল্টি সব কম্বিনেশনস করে আমাদের দিতে হয়, অ্যান্ড দ্য কস্ট অফ বার্ডেন অফ দ্যাট অ্যান্টিবায়োটিক ইজ ভেরি ভেরি হাই। এক একটা দাম হচ্ছে পার অ্যান্টিবায়োটিক ৩,০০০ টাকা, ৪,০০০ টাকা, ট্রিপল টিডিএস ডোজে আমাদের দিতে হয়। So whatever that, Acinetobacter is a multi-drug resistant. Only 2 to 3 antibiotics are available to treat the multi-drug resistant Acinetobacter. Pseudomonas, yes, same. খুব একটা হাতে অ্যান্টিবায়োটিক নেই। ক্লেবশিয়েলাও তাই। সো দিস অর্গানিজমস আর ফ্যাটাল। পেশেন্টরা এখানেই এসে আলটিমেটলি লাস্টে মারা যায়, আর তখন ক্রিটিক্যাল কেয়ারের কস্ট বার্ডেনটাও অনেক হয়। ওকে, so these are health care associated pneumonia. There is a term called VAP. You have to know the term called ventilator associated pneumonia. Healthcare associated pneumonia এমনিও পেশেন্টের হতে পারে, একটা পার্কিনসন্স পেশেন্ট ক্যানট কাফ আউট প্রপারলি, তার মুখে ওরাল কমন সেলস জমা হচ্ছে, সেটাই অ্যাসপিরেট করে তার নিউমোনিয়া হয়। তো ম্যাক্সিমাম হচ্ছে অ্যাসপিরেশন নিউমোনিয়া হয়। দ্য সেকেন্ড থিং হচ্ছে ভেন্টিলেটর অ্যাসোসিয়েটেড নিউমোনিয়া। Ventilator associated pneumonia, patients are in ventilator for at least 2 days and suddenly দেখলি যে একটা পেশেন্ট 10 দিন ভেন্টিলেটরে ভালো আছে, হঠাৎ করে তার অক্সিজেন ডিমান্ড বাড়তে থাকলো, পেশেন্ট হ্যাভিং আ ফিভার, পেশেন্ট হ্যাভিং আ হাই সিআরপি, হাই কাউন্ট, so then you might suspect, okay, this patient having a ventilator associated event or ventilator associated pneumonia, then you will go for further investigation. Now again come to cap. Streptococcus pneumonia followed by the mycoplasma pneumonia, the most common agent of the cap. Cap টার্মটা আস্তে আস্তে সবাই শুনে নে, বুঝে নে। In future, no one called you a community acquired pneumonia. Everyone will tell বা সবাই বলা বলি করবে, okay fine, this is a cap, right? Hap, cap, you কটি, এগুলো আস্তে আস্তে হ্যাবিচুয়েটেড হতে হয়। ওকে, others are H influenzae, chlamydophila pneumonia and viral pneumonia. প্যাথোজেনেসিস কি করে হচ্ছে নিউমোনিয়াটা আমাদের, কারণ আমাদের তো সবার তো লাংসে একটা প্রোটেক্টিভ মেকানিজম থাকে, তাহলে এই যে কোনো ভাইরাল ইনফেকশন বা ব্যাকটেরিয়াল ইনফেকশনই কি আমার সবসময় নিউমোনিয়া হবে? না, সবসময় হয় না। দুটো ফ্যাক্টর আছে, এক মাইক্রোবিয়াল প্যাথোজেন দ্যাট গেইন অ্যাক্সেস টু দ্য লাং অ্যান্ড দ্য হোস্ট রেসপন্স টু দ্য প্যাথোজেন। ফার্স্ট ইজ দ্য মাইক্রোবিয়াল প্যাথোজেন গেইন অ্যাক্সেস টু দ্য লাং। কি করে আমার ভাইরাস আর ব্যাকটেরিয়াটা লাংসে পৌঁছাচ্ছে? There are three methods, right? One is the inhalation technique, যে কোনো একটা জায়গায় কেউ আমার সামনে একটা কেসে দিল বা হেঁচে দিল, দিস পেশেন্ট অর সাফারিং ফ্রম, যেমন কোভিডে হতো, খুব হাই ট্রান্সমিসেবল রেট, জাস্ট পেশেন্ট তোর কাছে একটা কেসে দিলে, হেঁচে দিলে, সঙ্গে সঙ্গে তোর ইনহেলেশনের মাধ্যমে that viral particle will lodge into the via aerosols to your lung. This is the one method. Another method is the aspiration to your oropharynx. Anyhow, অনেক পেশেন্ট, যেটা বললাম একটু আগে, the patient একটা পার্কিনসন পেশেন্ট বা প্রপারলি খুব ওল্ড এজ পেশেন্ট যে প্রপারলি কাপ আউট করতে পারে, তো কি হবে? তার অর্গানিজমস গুলো তার হচ্ছে আমার স্যালাইভা বা মুখে হচ্ছে আমার ওরোফ্যারিংসে সেগুলোতে আস্তে আস্তে লজ করতে থাকে। তো দ্যাট সামটাইমস সেইটা আমার কি করবে, অ্যাসপিরেট করে লাংসে চলে যাবে। দ্যাট ইজ অ্যানাদার মেথড। ম্যাক্সিমাম হসপিটাল অ্যাকোয়ার্ড নিউমোনিয়া গুলো এইভাবেই হয়। সো ওরাল hygiene maintaining is one of the most important part to prevent VAP. And another is the hematogenesis. Suppose পেশেন্টের ইউটিআই হয়েছে, ইউরিনারি ট্র্যাক্ট ইনফেকশন, সেখান থেকে রেট্রোগ্রেড আলটিমেটলি ওটা কিডনিতে পৌঁছাবে, কিডনিতে পৌঁছে সে হচ্ছে ব্লাডে চলে গেল, রাইট? ব্লাড থেকে এবারে পৃথিবীর সব জায়গায় যেতে পারে, সে গিয়ে লাংসে যেতে পারে, লিভারে যেতে পারে, সব জায়গায় যেতে পারে, নিয়ে গিয়ে লাংসে লজ করলো, লাংসে গিয়ে সেখানে ইনফেকশন করলো। তো দি আর দ্য থ্রি পোটেন্ট methods to getting infection mechanism. হ্যাঁ, আমাদের সবারই সিলিয়ারি রুট, সেইটা হচ্ছে কি করবে, যখনই আমাকে কোনো কিছু একটা পার্টিকেল ঢুকে যায় সঙ্গে সঙ্গে আমাদের কাপ এসে যায় না, তো দ্যাট সিলিয়া সবসময় আমাদের সেটাকে বাইরে বার করে দেওয়ার চেষ্টা করে, কিন্তু যখন সেটা পারে না, দেন we have an infection. The host immune response, once the microorganism reach the lung, engulfed by the resident alveolar macrophage, killed or eliminated by the mucociliary escalator through the lymphatics, clinical pneumonia manifests. HAP or hospital acquired pneumonia. Hospitalized patient increased risk of developing pneumonia attributed to the presence of ventilator. We have discussed this thing. Normal respiratory flora of hospitalized patient displaced by multi-drug resistance gram-negative organism present in the hospital environment. ক্লিনিক্যাল ম্যানিফেস্টেশন, লোবার নিউমোনিয়া, ইন্টারস্টিশিয়াল নিউমোনিয়া। লোবার নিউমোনিয়া কারা কারা করছে? টিপিক্যাল নিউমোনিয়া, নিউমোকক্কাস, মোস্ট কমন এজেন্ট, অ্যানাদার ইজ এ হিমোফিলাস ইনফ্লুয়েঞ্জা, স্ট্যাফ, ক্লেবসিয়েলা। দিজ আর দ্য লোবার নিউমোনিয়া। অ্যান্ড অ্যানাদার ইজ, দিজ আর অল আর এমসিকিউজ, রাইট? মানে এগুলো ভালো করে জেনে রাখ, করে রাখ। দিজ আর দ্য পোটেন্ট এমসিকিউজ, মানে এই যেগুলো বলছি। ইন্টারস্টিশিয়াল, এমবি তো ছেড়ে দে, এমনি পাস করে যাবে তোরা। Interstitial or atypical pneumonia. The chlamydophila pneumonia, mycoplasma, viral or fungal agent causing pneumonia, legionella. So this is a CT scan picture. These are the, you can see the lower lobe involvement. এই যে সাদা সাদা হয়ে যাচ্ছে, the black portion is the normal lung parenchyma. এই যে whitish হয়ে আছে, these are the pneumonia part. অনেক সময় এক্সরেতে আমরা ধরা পড়ে না, সিটি স্ক্যানে অনেক হাই রেজলিউশনে আমরা সেটা দেখতে পাই। ক্লিনিক্যাল ফিচার, আই স্কিপ দিস থিং বিকজ মোটামুটি এটা সবারই জানা। ট্রিটমেন্ট, আমরা কি করে কি চিকিৎসা দেবো? এম্পেরিক রেজিমেন্টস অফ দ্য ডিফারেন্স অফ ইনপেশেন্ট অ্যান্ড আউটপেশেন্ট। মোটামুটি একটা পেশেন্ট যদি ফার্স্ট আমার কাছে দেখাতে আসে ওপিডিতে, তাহলে সেই পেশেন্টকে আমরা অ্যাডমিট করব কি করব না, সেটা ডিপেন্ড করছে একটা স্কোরিং সিস্টেমের উপরে, কার্ভ 65। এনি কাইন্ড অফ নিউমোনিয়া প্রেজেন্ট টু পেশেন্ট comes to you, either this patient need a IV antibiotics or hemodynamics monitoring, need a hospital admission, কি করে বুঝবি? by কার্ভ 65 score. যদি কার্ভ 65 স্কোর যদি বেশি থাকে একের ওপরে, then you will admit। আসছি এটাতে। নাও there are দুটো টাইপের আমরা অ্যান্টিবায়োটিক দিই। One is a proper gram negative coverage. If you are suspecting patient might have a gram positive, you can give a MRSA, but MRSA coverage generally আমরা প্রথমেই দিই না। ফার্স্ট একটা কভারেজ দিই অ্যাটিপিক্যাল নিউমোনিয়ার জন্য। অ্যাটিপিক্যাল নিউমোনিয়ার জন্য অ্যান্টিবায়োটিক্স আর অ্যাভেলেবল লাইক ডক্সিসাইক্লিন, এটা আমার খুব ফেভারিট ড্রাগ, হ্যাভিং আ ব্রড স্পেকট্রাম অফ কভারেজ। অ্যাটিপিক্যাল নিউমোনিয়া, স্ক্রাব টাইফাস, তারপরে হচ্ছে তো গ্রাম নেগেটিভ অ্যাজ ওয়েল অ্যাজ গ্রাম পজিটিভ, কিছু কিছু জায়গা বলা হয় নাকি এমআরএসএ কভারেজও আছে। তো ডক্স ইজ এ ভেরি গুড অ্যাপ্রোচ, মানে অনেক সময় এখন এনি কাইন্ড অফ আনডিফারেন্সিয়েটেড ফিভারে ডক্সিসাইক্লিন ইজ প্রেফার্ড হয়। So one is a doxycycline or azithromycin or levofluoroquinolone group of antibiotic that can treat atypical pneumonia. কিন্তু ফ্লুরোকুইনোলোন আমরা জেনারেলি লাংসের ক্ষেত্রে দিই না। কেন দিই না? বিকজ ফ্লুরোকুইনোলোন, লিভোফ্লক্সাসিন, কুইনোলোন গ্রুপ এখানে এফেক্ট অফ টিবি। টিবি যদি হয়, যদি পেশেন্ট হতে তো পারে একটা কাফ, পেশেন্ট মাইট হ্যাভ এন টিবি, তো সেইখানে কিন্তু সিঙ্গেল এজেন্ট যদি আমি ফ্লুরোকুইনোলোন দিয়ে দিই তাহলে রেজিস্ট্যান্স ডেভেলপ করবে। তো নেভার গিভ ফ্লুরোকুইনোলোন টু আ LRTI পেশেন্ট উইদাউট ডুইং আ সিবি ন্যাট, টিবিটাকে এক্সক্লুড না করে, রাইট? তো সেক্ষেত্রে আমার অ্যাটিপিক্যাল নিউমোনিয়ার জন্য আমার অ্যাজিথ্রোমাইসিন অর ডক্সিসাইক্লিন আর একটা প্রপার গ্রাম নেগেটিভ কভারেজ, সেটা আইদার উই ক্যান স্টার্ট উইথ এ সেফিক্সিম অর সেফালোস্পোরিন, আইভি সেফট্রাক্সোন or BLBLI, piperacillin tazobactam, whatever. These are the approach to how to treat a patient of a pneumonia. Now, CAP 65 score. CAP 65 score ki? CAP 65 score if no comorbidity patients, oral amoxicillin, doxycycline given, ঠিক আছে, CAP outpatient ছেড়ে দে এটা। CAP 65 টা কোথায় গেল? Oh, now the prognosis of the CAP can be predicted by a scoring system called CAP 65. C for stands for confusion of a new onset. 1 point. U for a blood urea nitrogen. It is a more than 19. It's a 1 point. Respiratory rate more than 30. That is a 1 point. Blood pressure less than 90 by 60. 1 point. তাহলে টোটাল কত হলো? আর এজ greater than 65 years. যদি হায়ার দ্য স্কোর গ্রেটার ইজ দ্য মর্টালিটি। যদি আমার স্কোর একের বেশি থাকে, মোর দ্যান 1, পেশেন্ট শুড বি হসপিটালাইজ। যদি আমার লেস দ্যান 1 বা ইকুইভ্যালেন্ট 1 থাকে, পেশেন্ট আউট পেশেন্ট আমরা চিকিৎসা দিতে পারি, মানে ওরাল অ্যান্টিবায়োটিক দিয়ে আমি পেশেন্টটাকে ছেড়ে দেবো। আর যদি মোর দ্যান 1 হয় তাহলে আমি পেশেন্টটাকে অ্যাডমিট করে চিকিৎসা করবো, রাইট? দিস ইজ দ্য কার্ভ 65. বেসড অন দ্যাট উই ক্যান ট্রিট দ্য পেশেন্ট either in OPD or IP. টিবিটা স্কিপ করছি, টিবিটা সেপারেট ক্লাস হবে। Lung abscess. Lung abscess represent the necrosis and the cavitations of the lung following microbial infections. Normal কি হচ্ছে, LRTI তে patients having a just a pneumonic patch, patient having a fever বা একটা, এখানে কি হবে, হোল একটা টোটাল আমরা লাংসে টোটাল ক্যাভিটারি লেশনস তৈরি হবে। can't diagnosis without a CT scan. প্রপারলি সিটি স্ক্যান করলে এটা আমরা বুঝতে পারবো। অনেক সময় একটা মাস লাইক অ্যাপিয়ার থাকে, তো কন্ট্রাস্ট এনহ্যান্স সিটি স্ক্যান ইজ বেটার চয়েস। So lung abscess represent necrosis and cavitation usually present as a single cavity of more than 2 cm. Primary lung abscess account for 80% of cases, results for aspiration and maximum abscess টা কি, সেই জায়গাটা একটা ক্রনিক্যালি একটা নেক্রোসিস তৈরি হচ্ছে, that part of that area পাস ফর্মেশনস হচ্ছে, সেই জায়গায় নেক্রোসিস হতে হতে আর সেখানে কি হবে, ব্লাড সাপ্লাই পৌঁছাতে পারবে টিস্যুগুলোতে অ্যাট দ্যাট এরিয়া? না, রাইট? তাহলে আমার যদি ব্লাড সাপ্লাই না প্রপারলি পৌঁছাতে পারে, তাহলে ওইখানে আমার একটা কি এনভায়রনমেন্ট ক্রিয়েট হচ্ছে, অ্যানারোবিক এনভায়রনমেন্ট, মানে অক্সিজেন ব্লাড না গেলে তো আমার অক্সিজেনও যাবে না, রাইট? তাহলে অ্যানারোবিক এনভায়রনমেন্ট যদি ক্রিয়েট হয়, তাহলে যে কোনো নেক্রোসিস পেশেন্ট you might have an suspicion of a anaerobic infection. তাই যে কোনো আমার অ্যাবসেস কে যখনই আমি চিকিৎসা করব, ট্রিটমেন্ট দেবো, মাই ট্রিটমেন্ট অফ চয়েসে অ্যান্টিবায়োটিকে যেন একটা অ্যানারোবিক কভারেজ থাকে। So here the clindamycin is a drug of choice. Clindamycin having a good anaerobic coverage. So primary lung abscess account for 80% of cases result from aspiration caused by anaerobic bacteria. Secondary lung abscess arises due to the bronchial foreign body or tumor or immunocompromised conditions like HIV. Others cause গুলোতেও থাকতে পারে। Common organisms Staph aureus, gram-negative brods, Pseudomonas, Legionella, fungi, Streptococcus and Pneumocystis jirovecii. This is the secondary lung abscess যেগুলো বলছি। Clinical manifestations. Initially lung abscess present similar to the pneumonia, fever, productive cough, same manifestations. In anaerobic etiology, progression is slow and indolent, night sweats, fatigue, occasionally foul-smelling sputum. In case with non-anaerobic etiology, S. aureus course is more fulminant with rapid progression. কখনো কখনো Staph aureus হতে পারে। Primary lung abscess, clindamycin is the first antibiotic choice, যেটা বললাম। Secondary lung abscess, antibiotic coverage, pathogen directed and based on the culture susceptibility report. Whatever the condition it is, অ্যানারোবিক মানেই একটা লাং অ্যাবসেস পেলাম মানেই যে আমি তাকে ক্লিন্ডামাইসিন দিয়ে চিকিৎসা করবো এরকম কথা নয়। সেটা একটা এমআরএসও হতে পারে, অ্যাসিনেটও হতে পারে। ইউ হ্যাভ টু ডু আ প্রপার ব্রঙ্কিওঅ্যালভিওলার ল্যাবাজ পাঠিয়ে সেখানে আমাকে কালচার রিপোর্টের জন্য ওয়েট করতে হবে। যে জায়গায় আমার লিশনসটা হয়েছে আমাকে একটা স্কোপ ঢুকিয়ে, দ্যাট ইজ কল্ড ব্রঙ্কোস্কোপ, সেখান থেকে প্যাথোজেনটাকে আমি ওখানে ফ্লুইড দেবো, ওয়াশিং করবো, নিয়ে ওটাকে কালেক্ট করবো এবং সেটাই আমি ল্যাবে পাঠাবো। সেখান থেকে আমি দেখবো কি অর্গানিজমসটা আসছে। প্রপার কালচার রিপোর্ট পেলে দেন সেটা দেখে আমরা অ্যান্টিবায়োটিকটা চয়েস করবো। Pleural effusion and empyema. Pleural effusion, the fluid in the lung, that is called pleural effusion. Empyema means এই ইফিউশনটাই আস্তে আস্তে আরো থকথকে হয়ে গেছে, কাদা কাদা হয়ে গেছে, দ্যাট ইজ কল্ড এম্পাইমা। ঠিক আছে, refers to the presence of an excess quantity of fluid in the pleural space, an area which lies between the lung and the chest wall. তাহলে যে আমার যে প্লুরাল স্পেস থাকে সেই স্পেসে যখন আমার জল ভরে যাচ্ছে, দ্যাট ইজ কল্ড বাংলা what? Pleural effusion. And that can be a three types. First is a any kind of bacterial infection করতে পারে, that is called প্যারানিউমোনিক ইফিউশন। আর ব্যাকটেরিয়া করলে সেখানে তো পাস হবেই, তার ডেন্সিটি বাড়বে, and that is called এম্পাইমা। ওকে, জল জল কনভার্টেড ইনটু কাদা, আমাদের স্যার এটাই বলতো। দ্যাট ইজ কল্ড প্যারানিউমোনিক ইফিউশন। অ্যান্ড অ্যানাদার ইজ এ টিউবারকুলার প্লুরাইটিস, টিবি থেকেও প্লুরাল ইফিউশন হয়, that is called tubercular pleuritis. Another is a viral infection followed by a effusion, that is called viral pleural effusion. How can you distinguish that parapneumonic, tubercular and viral? There is a separate তোর কিছু মার্কার্স আছে, আই থিঙ্ক বায়োকেমিস্ট্রিতে পড়িয়েছে রাইট তোদের এটা, যে প্লুরাল ফ্লুইডের কি কি হতে পারে, এডিএ দেখা, নিউট্রোফিল কাউন্ট, তারপরে হচ্ছে আমার গ্লুকোজ, যেমন আমার যদি ব্যাকটেরিয়াল ইনফেকশন থাকে গ্লুকোজ অনেক কম থাকবে, টিবি থাকলে গ্লুকোজ অনেক কম থাকবে। Neutrophil count is higher in a bacterial infection, where lymphocytes in higher in TB and viral infections. Total count is very high in case of parapneumonic infusion. Viral এ আবার total count টা কম হবে। So there are the separate criteria. এটা মেডিসিনও আবার তোরা পড়বি। Now lab diagnosis. Lab diagnosis of the LRTI specimen collections. So LRTI মানে ফার্স্ট লং ইনফেকশন, মানে ফার্স্ট তোর মাথায় আসবে স্পুটাম, স্পুটাম, অ্যান্ড অ্যানাদার উই হ্যাভ টকড অ্যাবাউট ব্রঙ্কোঅ্যালভিউলার লাভাজ। এবার ব্রঙ্কোস্কোপি করে আমরা অনেক কিছু পাঠাতে পারি, ব্রঙ্কোঅ্যালভিউলার লাভাজ হতে পারে, দ্যাট ইজ এ ট্রান্স ট্র্যাকিয়াল অ্যাসপিরেশনস হতে পারে, অ্যান্ড অ্যানাদার ইজ এ ব্রঙ্কিয়াল ব্রাশিংস হতে পারে। So mainly you can say that bronchoalveolar lavage is enough. Another is a sputum and another is a pleural fluid sampling. So fluid. So these are the three types of sample you can set. So sample collections আগের দিন যেটা বলেছিলাম ল্যাব ডাই যখন লিখবে, তো দেয়ার আর প্রত্যেকটা ল্যাব ডাই হচ্ছে ইউনিক। এখানে হচ্ছে আমার তিনটে স্যাম্পলস আসবে রাইট, কি কি? স্পুটাম, bronchoalveolar lavage and another is a pleural fluid. Transport is more or less same, within 2 to 4 hours এর মধ্যে আমাকে পাঠিয়ে দিতে হবে। and after that what we will do, gram stain, then sputum quality চেক করতে হবে, আইদার যে পেশেন্টটা পাঠিয়েছে স্পুটাম পাঠিয়েছে না সালাইভা পাঠিয়ে দিয়েছে। অ্যাসিড ফার্স্ট স্টেনিং, জিএমএসএস স্টেনিং। স্পেসিমেন শুড বি কালেক্টেড বিফোর অ্যান্টিবায়োটিক থেরাপি, সেটা এটা একটা ইম্পর্টেন্ট। যে কোনো ল্যাব ডায়াগনোসিসে বা আমাদের সেটা আগে দেখতে হবে পেশেন্ট ইজ অন অ্যান্টিবায়োটিক অর নট। if patient is on antibiotic, you might have a less chance of getting organisms, right? Already patient এর তখন organisms গুলো মরে গেছে, একটা রিপোর্ট দিয়ে দিলি নো কালচার সেন্স। বাট অলওয়েজ লুক ফর দ্যাট প্রপার, যে কদিন বাইরে অ্যান্টিবায়োটিক পেয়েছে কিনা, এখানে এসে কদিন অ্যান্টিবায়োটিক পেলো, তারপরে পেশেন্টটা স্যাম্পল পাঠাবে। ইউটিআই অর এলআরটিআই, হোয়াট এভার দ্য principle টা same. Patient is on antibiotic, you have a less chance of getting culture in your lab, positive in your lab, right? Then sputum culture, standard culture method for pneumonia. Specimens are inoculated into blood agar, chocolate agar and McConkey agar and incubated overnight. Blood culture perform addition, especially in hospitalized patient, কারণ অনেক সময় বললাম হিমোটোজেনাস রুট থেকেও আমার ইনফেকশন থাকতে পারে। So we have to do consistently both of sputum culture as well as blood culture. For lung abscess, primary lung abscess, lung aspirate, subjected for anaerobic culture. Secondary lung access sputum blood culture can be performed for TB patients inoculated or LG medium fungal pathogen isolate in HDA agar. Now for serology testing, mycoplasma, cold agglutination test, ELISA, chlamydial antibiotic, microimmunofluorescence test, Q fever, indirect immunofluorescence. So these are the kind of serology tests, antibody detections are available. যেখানে আমাদের কালচার অনেক সময় নাও পেতে পারি, কিন্তু আমার ডায়াগনোসিসে বাই অ্যান্টিবডি ডিটেকশন ইন ইউর ব্লাড উই ক্যান ডিটেক্ট। অ্যান্টিজেন ডিটেকশন সেম একই মেথড, এখানে আইসিটি থাকছে। যেমন নিউমোকক্কাস ইজ ভেরি ডিফিকাল্ট টু আইডেন্টিফাই থ্রু ইউর স্পুটাম অর ব্লাড কালচার, কিন্তু অনেক সময় যদি আমার ইউরিন স্যাম্পল পাঠিয়ে দিই, ইউরিন স্যাম্পলে আমার এটা চলে আসে অ্যান্টিজেনটা। সো ডিটেকশন অফ দ্য নিউমোকক্কাল অ্যান্টিজেন ইন ইউরিন বাই আইসিটি। Enzyme immunoassay ELISA detect L pneumophilia serogroup of one specific soluble antigen in urine. Direct fluorescence antibody test, influenza virus and respiratory virus. And lastly, all the PCR technique, multiplex PCR, pre-array or biofire, real-time PCR and automated real-time PCR. এইগুলো মোটামুটি সব এক, লাস্টে এটা লিখে দেবো।
You will go for practicing. There are so many systemic diseases, but nowadays, for the immune deficiency, there are fungal incidences are much more. There are so many patients suffering from fungal diseases. Previously, it was more or less neglected disease, but nowadays it is very much important. After HIV, as HIV causes immunosuppression, which will cause aggravation of the fungal disease. Now, medical mycology. A bit recapitulation. Fungal cell is prokaryotic or eukaryotic? Fungus prokaryotic or eukaryotic? Eukaryotic, and bacteria is prokaryotic. Okay. Now, what is the difference between the eukaryotic and prokaryotic? Fungal cell, I have told it is eukaryotic. That means like cell of plant and other animal, etc. Now it has, you can see the structure which is not present in the bacteria or prokaryotic cell, which is present in the eukaryotic cell. Those are, it has rigid cell wall, it contains sterol, nucleus is there, definite nucleus with nucleolus and nuclear membrane, which is absent in case of bacteria. Bacteria has only chromosomal mass. There is no definite nucleus or nucleolus or nuclear membrane, but here is definite nucleus. There is Golgi apparatus and endoplasmic reticulum, which is absent in case of prokaryotic or bacteria. It has mitochondria, which is absent in the bacteria or prokaryotic cell. So, of eukaryotic cell or a fungal cell, this is the main structure. You can see this is the cell membrane, yellow color. This is the cell wall. This is the nucleus with nuclear membrane. This is Golgi apparatus. This is mitochondria, and this is vacuole, and this is lipid granule. Next, classification of fungus. For the oral examination and for short note, fungus is very much important. So, classification, there are two types of classification. One is taxonomical classification and another is morphological classification. Taxonomical classification, you can see zygomycetes, ascomycetes, basidiomycetes, deuteromycetes. There are so many new terminology which is very difficult to utter, but you have to keep it in mind. So, taxonomically, there is again zygomycetes, ascomycetes, basidiomycetes and deuteromycetes or fungi imperfecta. Next comes morphological classification. That means according to morphology. According to morphology, again it is 4 types. That is yeast. Yeast it is also helpful to human or for business purpose. You know what is the use of yeast? তোমরা জানো ব্রেড পাউরুটি তৈরি করতে ইস্ট লাগে বাট উই নো ফাঙ্গাস ইজ notorious causing so many diseases, but one important antibiotic first derived from fungus, can you say the name? Penicillin. Penicillin, you know, from one fungus penicillin was derived. And fungus we are also taking as food, you know. What is mushroom? Mushroom we are taking as food, and for fermentation, for preparation of bread, yeast is required. So these are uses of fungus, but otherwise they are causing so many diseases to the human and animal. Now, morphological classification: one is yeast, one is yeast-like fungus, one is mold, one is dimorphic fungus. My topic is today dimorphic fungus. So, what is the meaning of dimorphic? Dim is two, you know, morphic means morphology. It has two types of morphology at defined temperature. At 20 to 25 degrees centigrade, these group of fungus lies in mycelial form or filamentous form or branching form. But when you put it at 37 degrees centigrade at culture, it will produce yeast form. So two types of morphology, same fungus, so it is called dimorphic fungus. These are dangerous and important as these group of fungi are causing systemic diseases. Okay, so many systemic diseases are caused by dimorphic fungi. So yeast, I have told yeast is single celled yeast. I will show you picture. Then yeast-like fungus, that is not true yeast but yeast-like. Example is Candida. Candida, you have heard the name Candida. Candida infection, very common infection. So Candida is yeast-like fungus. What is the example of yeast? True yeast. Anyone can tell? Cryptococcus. Nowadays, after immunodeficiency, in case of HIV patients, there is chance of cryptococcal infection, mainly in brain. It causes meningitis, which is very much serious. So, in case of HIV infection, there is chance of cryptococcal infection. Cryptococcus, it is true cyst, and yeast-like fungus is Candida. Next comes mold. Mold means branching stage of the fungus. Dimorphic, I have told, same fungus lying in two different types of morphology at two different types of temperature. Again, keep it in mind as dimorphic fungi is very important for short note. As very important, I am telling that it is causing so many diseases. Now, again for repetition, at 20 to 25 degrees centigrade, it remains as mold or branching form. At 37 degrees centigrade in incubator or in human body, it lies at yeast form. Next picture you can see, this is yeast. Yeast you can see, and here is the budding. This is the budding. In bacteria, you know, reproduction is binary fission. Okay, but in case of yeast, there is budding. One bud is formed from the cell. Next, it is detached. Another fungi is produced. This is called germ tube. Germ tube, it is seen in Candida. In Candida, germ tube is seen. That is elongation of the fungus. And if it is longer enough, জাস্ট লাইক তোমরা দেখেছো ছোলা ভেজালে একটা কল মতো বেরোয়, ঠিক এই ফাঙ্গাসেও এইরকম কল জাতীয় জিনিস দেখা যায়, হুইচ হেল্পস ইন আইডেন্টিফিকেশন। That is called germ tube. It is only seen in the Candida, and to differentiate Candida from different species of Candida, as Candida albicans, Candida tropicalis, Candida krusei, Candida parapsilopsis. There are so many species of Candida to identify Candida albicans, which is most common and most important. We can differentiate by testing germ tube. Next comes hypha. Hypha, this is true hyphae, this is true hyphae, this is pseudo hyphae. True hyphae, one is septate, there are septa, and one is aseptate, no septa. Hyphae, that is branching or mycelial form. And what is pseudo hyphae? It is looking like hypha, but it is not actually hypha. Presci, like a balloon, it will be elongated. More elongated. So now it is looking like a hypha, but it is not actually hypha. So it is called false or pseudo hypha. So if there are budding, you see, this is one candida, another, another. If there is pressure, what will happen? This is looking like hypha, but there is constriction, and this is separate cell, this is separate, no communication is there. So it is called pseudo hypha. It is seen in the Candida species. But where is true hypha? True hypha, there is no constriction, there is no constriction, there is communication. If there is septation, there is septa is there, but there is communication also. So if septa is there, it is called septate. If no septa, that is called aseptate hyphae. And this is mycelium. That means basal or neck of mycelia is called mycelium. Now reproduction and sporulation. Reproduction and sporulation. There are two types of spore. One is sexual spore, another is asexual spore. Sexual spore, everything you have to keep it in mind. Okay, as all these are coming as short note. I am telling this, it is coming as short note. Now sexual spore, zygospore, ascospore, basidiospore. Zygospore, there are two different male, female you can think, and one spore is formed. Ascospore, ascus means bag or tholi. Within this, spore are there. So it is called ascospore. This is basidiospore. Basidio means there is must base, just like flower of hush. Within this, conidia is there. So this is called basidiospore. All these are sexual spores. There are asexual spores. One is vegetative form, one is aerial form. Vegetative form, that means when fungus goes within the media, that is vegetative form. When it is coming out of the media in the air, that is called aerial hyphae or aerial reproduction. Now vegetative spore, what are the different vegetative spore? That is, this is arthrospore. Just brick-like fragmentation. These are arthrospore. It is found in the dermatophyte, which causes cutaneous fungal infection. Arthrospore. This is chlamydospore. This is seen in case of Candida. Candida. When Candida is cultured in nutritionally deficient media, then we can see chlamydospore. All these are separation or identification of the fungus. Identification of the Candida from other fungus. This is chlamydospore. These other spores are sporangiospore. These are the spores. This is the sporangium. This is conidiospore. At the top you can see these are blastospores. There are so many spores. These are aerial spores. Now lab diagnosis. You can write this lab diagnosis of the fungal infection. So when there is any identification of fungus, these are the same steps you have to write. These are same procedures you have to go. That is, first, for every diagnosis you have to take specimen. Okay. So fungal infection, it is occurring on the skin, on the nail, on the hair, or systemic diseases, lungs, etc. Then we have to take the specimen, nail, hair, skin. In case of lung infection, sputum. In case of meningitis, I have told cryptococcal meningitis, CSF. So these are the specimens. So for every diagnosis, you have to go through same steps. Okay, Shayan, please. After taking the specimen, we have to go for direct microscopy. Everything first, for the diagnosis, you have to go in bacteria, we are going for gram stain, Zn stain, then we see under microscope. Here also we have to see under microscope, but here not gram stain is done. What is done? After taking the material, we have to use potassium hydroxide preparation, KOH. So what are the different percentage? 10%, 20%, 40%, according to thickness of the material. If it is skin, it is soft, so 10%. If it is nail, 20 to 40%. So in this way, we have to use potassium hydroxide with the material, then we see under microscope. Under microscope, we can see these are the fungal hyphae. You can see these are the hyphae, that is branch, fungal hyphae. These are the budding yeast. One yeast budding is there. One yeast budding is there. This is KOH test positive slide of sputum. This is a sputum slide after KOH preparation. Okay. Then other test, KOH with chalcofluor white. Fluorescence dye we use for identification. Here for fungus, we have to use chalcofluor white. There will be glistening of the fungus. We can see under UV light, under UV microscope, fluorescent microscope. Then we can also go for gum stain, but first we have to go for KOH preparation. Gum stain, candida can be seen better in gum stain. Then India ink preparation. What is the use? Anyone can tell what is the use of India ink? Negative staining. Why? For which diagnosis? কেন আমরা কি দেখার জন্য ইন্ডিয়া ইঙ্ক করি? ক্যাপসুল। ক্যাপসুল। ফর ক্যাপসুল we have to go for India ink preparation. কার ক্যাপসুল আছে কোনো ফাঙ্গাসের? একটু আগে বললাম ক্রিপ্টোকক্কাস, যেটা মেনিনজাইটিস করে। Cryptococcus has thick capsule which helps us for diagnosis. So it is an importance for Cryptococcus. Capsule is double the original cell. So by seeing the capsule, we can diagnose Cryptococcus. Why it is so important? As Cryptococcus is causing meningitis. There are so many other diseases, but meningitis which may lead to death of the patient immediately. Now culture. So for bacteria, for fungus, we have to go for culture. Here is also media is there. Orally asked, what is the media? This is SDA. Full form? Full form? Sabouraud's dextrose agar. Asked in the oral examination. Full form? Sabouraud's dextrose agar. Okay. And there is also SDA with antibiotic. Why with antibiotic? If there is culture, when we are taking material, it may be mixed with not only fungus with bacteria. So it will be difficult to identify whether it is bacteria or fungus. So to kill the bacteria, we have to use antibiotic. So only fungus will grow. Okay. So here we are using SDA with antibiotic. Next, BHI, brain heart infusion agar. Brain heart infusion agar. It is not used for bacteria. For bacteria we are using McConkies agar, nutrient agar, blood agar, etc. Not SDA or not BHI. Okay. It is for especially for fungus. So blood agar, BHI agar, we mixed enriched with blood and antibiotic to kill the other bacteria. Only fungus will grow. Then other tests for lab diagnosis. You can write or can take the picture as for fungal disease, they have to go through this lab diagnosis. Okay. So I have told microscopy, that is KOH preparation, then India ink preparation, then gum stain, then culture, next other test. For germ tube test, it is to diagnose Candida species. Candida species germ tube. Urease test. Urease test in bacteria, you know, urea positive, where Klebsiella, urea positive. Here is also urea positive in Cryptococcus. So for Cryptococcus, we have to go India in preparation, then biochemical urease test. Here perforation test, চুলের fungal infection হয়, that is trichophyton. So here perforation test is done for diagnosis. Tissue section, biopsy also taken if there is lung infection by fungus, hepatic infection, we have to go for tissue section. Lymph node infection by fungus, we have to go for biopsy. Tissue section is tested by this stain, GMS, Gomori methenamine stain. Gomori is methenamine stain used for biopsy material. Pass. Periodic acid skip. You have to mention these points for lab diagnosis. So for biopsy to diagnose fungus, you have to go for GMS or pass, periodic acid skip. Serology. Everywhere you have to go for serology, as serum contains the antibody, mainly antigen also. So for antigen detection, latex agglutination test for Cryptococcus, which is present in the CSF. Then antibody detection, against agglutination test, ELISA, immunodiffusion test, etc. Then molecular method PCR. It is written here, molecular method PCR. Everywhere you have to mention these steps for lab diagnosis. Now classification of fungal disease. Now fungal disease, I am going to fungal disease. Now three types of superficial fungal disease, commonly skin, you can see ringworm, etc. Skin disease, fungal disease, very common. So superficial layer, which involves superficial mycosis, and here skin, hair, nail, and positive fungus is dermatophyte. Okay, always you may face the question, name one fungus which causes superficial mycosis. So answer is dermatophyte. Next, subcutaneous mycosis, infection which is going a bit deep, not only skin, a bit deep, that is subcutaneous tissue. And what are the diseases? Mycetoma, sporotrichosis, rhinosporidiosis. Very tough to utter, but you have to keep it in memory for exam purpose and for your practice purpose also. Next comes systemic mycosis. Systemic mycosis, that means fungal disease which involves our system, not only skin, not only subcutaneous tissue, but system, that is brain, heart, liver, GI system, thoracic system, etc. Now here comes the dimorphic fungi, which is my topic today. Dimorphic fungi, that is Histoplasma capsulatum. DM means dimorphic fungi. Histoplasma capsulatum, Blastomyces dermatidis, Paracoccidio brasiliensis, Coccidioides limitis. Very difficult to utter, but still you have to remember it. Okay. So if asked, name some dimorphic fungi which causes systemic disease, that is Histoplasma capsulatum, Blastomyces dermatidis. As space was short, I have omitted so many letters. Paracoccidio brasiliensis, Coccidioides limitis. Here Cryptococcus, it is not dimorphic fungus, but it is yeast, but it causes systemic mycosis also. Next, dimorphic fungi, Histoplasma capsulatum. Histoplasma capsulatum causing histoplasmosis. Disease is histoplasmosis. It is a disease of RE system, reticuloendothelial system. It is intracellular parasite. Source, soil enriched by excreta of bat and bird. You can see this is bat, this is a bird. Their excreta contains this fungus. So excreta is going to the soil. So So soil is mixed with this histoplasma capsulatum. Those person who is working that place, during inhalation, spore can enter through the nose, go to the lung, causing the disease. First, disease in the lung. Okay, and here its importance, it first goes to the RE cell, reticuloendothelial system. So you can see the picture, lung is infected, this is one person, these are the excreta, it is inhaled by that person, going to the lungs, so infection of the lung, then it may ultimately goes to the RE system, I will show you picture later. So reticuloendothelial system, it goes ultimately where it increases or reproduces. So infection by inhalation of the spore. Every dimorphic fungi, first infection in the lung by inhalation of the spore. So first infection in the lung, from the lung disseminated to other, that is skin, lymph node, liver, etc. So first infection in the lung by inhalation of conidia from the surroundings. You can see these are the histoplasma spores from the bird excreta lies in the soil. It is inhaled by the person and going in the lung. Okay, so majority asymptomatic, but everyone is not affected by the disease. Those who are immuno compromised and who is inhaled huge number of conidia, there is chance of infection. Otherwise, they are asymptomatic. So, if infected, there is plasmosis, there may be fever, lymphadenopathy, hepatosplenomegaly, mucocutaneous lesion. That means mucous membrane and skin also involved. Lab diagnosis of histoplasmosis. Specimen, if there is lung infection, you have to take the sputum. As lymph node is involved, so you have to take the lymph node aspirate. Bone marrow is also taken, as it is the disease of RE system. Scraping from the mucosal ulcer, biopsy from lymph node. Those organs are involved, we have to take specimen from these organs. Microscopy by GM star or right stain, yeast in RE cell. This is the RE cell, reticuloendothelial cell. There are yeast. You can see these are the yeast. So yeast cells in macrophage or RE cell. Macroconidia. Macro means large conidia is there. Small conidia, microconidia. Culture. For diagnosis, everything you have to go for culture. Culture media is SDA, and in this histoplasmosis, culture is gold standard. So if culture is positive, diagnosis is complete. So media is SDA or BH agar. It is mixed with cyclohexadine and chloramphenicol. It is antibiotic, to suppress the bacterial infection and to suppress the other fungal infection. Only this histoplasma will grow. And I have told it is dimorphic fungi, so 2 types of temperatures required for incubation. It is seen at 37 degrees centigrade, yeast form, 25 degrees centigrade, white cottony mycelium with spherical spore with tubercle. These are the spore and there are tubercles. Serology, every diagnosis you have to search antigen and antibody. Antibody by latex agglutination test, precipitation test, complement fixation test. So same thing you have to utter for every diagnosis. Same serology, same antibody, same antigen detection, etc. So here antigen detection, ELISA from serum and urine. Histoplasma skin test. Histoplasma toxin can be taken and it is intradermally, like Mantoux test is inoculated, and then hypersensitivity is seen. This hypersensitivity is delayed type of hypersensitivity. That means not stacked reaction. It will take 48 hours. So it is called delayed type of hypersensitivity. Molecular, you know, every time for the lab diagnosis, you have to go for molecular test and you have to write PCR. And treatment for acute case, amphotericin B and chronic itraconazole. These two names you have to keep in mind. For fungal infection, one is amphotericin B, next is itraconazole. Next, another dimorphic fungi, blastomycosis. Blastomycosis. Causative agent is blastomyces dermatitis. It is omitted as space was narrow, so I have omitted some letters. So blastomyces dermatitis. These are the picture you can see. Disease, lung infection. I have told every dimorphic fungi first causes lung infection by the inhalation of the spore through nose, then disseminated to the skin, mucous membrane, lymph node, etc. So here is also lung infection, spread skin, bone, genitourinary tract. You can see picture. Inhalation of the conidia, so infection lung, then disseminated all over the skin. Source, inhalation of conidia from soil. Some may be asymptomatic, mild pulmonary disease, some may be dissemination to the skin lesions. Lab diagnosis of blastomycosis. Specimen, every I have told as infection lung to, so you have to take sputum. Skin infection, you have to take skin scraping. Lymph node involved, so you have to take biopsy from lymph node, etc. If there is ulcer, you have to take the pus. Microscopy 10% KOH, thick walled yeast, broad based bud. Here is yeast is thick walled and broad based bud. This is thick walled yeast and it has a bud. Base is broad. Bud is there, but base is broad and the wall is thick. It is the diagnostic point of histoplasmosis. And lymph node, etc. We have to go for the biopsy, that is hematoxylin eosin stain and PAS. PAS means periodic acid stiff. Periodic acid stiff for biopsy or hematoxylin eosin stain. And in the tissue, we will see yeast form. In the tissue, we will see yeast form, and at 37 degrees centigrade, we will see yeast form. Culture, again SDA and blood agar and BHA agar also, same antigen detection in urine and serum, same molecular test, that is by PCR. Treatment, amphotericin B. For every fungus you have to write amphotericin B. Next, it is better if it is liposomal amphotericin B. Next, Paracoccidio brasiliensis. Paracoccidio brasiliensis, it is also another dimorphic fungi. A very beautiful see to see. You can see this is the picture. Disease is chronic granulomatous disease of lung. So everyone I have told disease of the pulmonary infection by inhalation of the conidia. So infection of the lung and dissemination to skin, mucous membrane, lymph node. Source, same inhalation of spore from environment. This is the picture. So lab diagnosis same thing. Specimen you have to go for sputum as lung infection, PAS, biopsy. Direct microscopy, KH preparation, you will see yeast form and with multiple buds. This is yeast with multiple buds. This is yeast with multiple buds. Then culture, same SDA media as dimorphic, again 25 degree centigrade mycelium, 37 degree centigrade yeast form. Again antibody detected by ELISA agglutination test, skin test, it will show delayed type of hypersensitivity. Treatment, again amphotericin B and itraconazole. Coccidioidomycosis. It is also another dimorphic fungi, coccidioidomycosis. Same thing, infection in the lung, but not in our country. It is seen mainly in USA and Mexico. Source, same, inhalation of arthrospore from the dust. Here, one point you have to keep in mind, it is arthrospore, not conidiospore. It is arthrospore, it is inhaled. This is the arthrospore. Brick-like, this is chain articulated, but after disarticulation, spores are called arthrospore. These are the arthrospore. There are two types of cycle. One is saprophytic cycle, one is parasitic cycle. Saprophytic cycle, that means when it is lying in the soil or environment. Here, free arthrochonidia, it goes in the soil, it converted into septate mycelia. You can see mycelia or hypha, septa is there. Again, from this arthrochonidia, chain is formed, chain is breaks, and single it is entered in the parasitic cycle or human or animal. It is environmental cycle, and this is parasitic, that means in human or animal. In human, immature spores, after entry it becomes mature, and this is called endospore. It contains spherules. You can see these are uh, uh, excreted and inhaled through respiration, goes to the lung. Same thing, same thing. Breathing in fungus can cause infection of the lung. Okay. So specimen as infection in the lung, so sputum. If skin ulcer pass, if lymph node involvement, biopsy material, direct microscopy, KOH, plenty of matches, spherular biopsy, hematoxylin eosin stain and pus stain. Culture same 25° and 37° as it is dimorphic. 25 mycelium, 37 yeast form. So will be same, antibody detection, skin test same, delayed type of hypersensitivity, treatment same, amphotericin B. Penicillium marnefi. Okay, Penicillium marnefi. Penicillium, you know, that is not dimorphic, but Penicillium marnefi is dimorphic, and uh, now it is important opportunistic pathogen in HIV. So in HIV patient, we have to go for Cryptococcus, we have to go for Penicillium marnefi, not Penicillium. It causes multiple organ involvement. Now named Talaromyces marnefi. It is important short note, Penicillium marnefi. Now it is called Talaromyces, and disease is called disease is called Talaromycosis. Name is Talaromyces marnefi, and disease is called Talaromycosis, not Penicillium marnefi. But you have to write. Skin lesion is ওয়ার্টি মানে হার্ড হয়ে যাওয়া, শক্ত আঁচিলের মতো হার্ড হয়ে যায়। সো স্কিন lesion is ওয়ার্টি। Source, inhalation conidia from environment. You can see these are the yeast form, and this is Talaromyces marnefi whole picture. These are the conidia. This is the nose. You can see after inhalation it goes to the lung, infection in the lung. In the lung there is in the macrophage there is yeast form. In yeast there is binary fission like bacteria. Lab diagnosis of Penicillium marnefi, specimen from lesion and direct microscopy, right stain, yeast form. Same thing, culture 25° and 37°, but picture is different. Very important Penicillium marnefi. I will show you the picture. 25° centigrade mold, parts green aerial hyphae, brown vegetative hyphae, red diffusable pigment. This is the pigment. You can see Penicillium marnefi. There is red pigment. There is greenish aerial spore. Here is also red pigment. This is typically seen in Penicillium marnefi. And this is the Penicillium after lactophenol cotton blue stain, LCB, lactophenol cotton blue stain, we can see this type of penicillium. These are aerial spores. These are the yeast form. Next and last, sporotrichosis. It is called rose gardener's disease. যারা গোলাপের গাছ নিয়ে কাজ করে, কাঁটা ফুটে এটা হয়। So it is called rose gardener's disease. Rose gardener's disease. You can see this is sporotrichosis. It is dimorphic fungi. Positive agent Sporothrix kenki. Spelling is very difficult. Uttering also very difficult. Sporothrix kenki. It is nodular also of skin and subcutaneous tissue, and it is not going to the lungs. This is the dimorphic fungi. It is not going to the lungs. It is a disease of subcutaneous tissue, and after thorn prick or any injury, this fungus can enter and may cause this type of lesion. So through the thorn prick injury.